Good afternoon, all. Now we will go into the first lecture on behavior. What is behavior? Behavior is the manner in which a person acts or performs. It is any or all activities of a person, including physical action which are observed directly and the mental activity which is inferred and interpreted from the way a person shows his external behavior. So behavioral development of a child from birth to adolescence is something which we need to do to manage child's behavior. So it starts from birth to 2 years. We call that period infant. During this period, the child acquires the sense of trust, or acquisition of sense of trust happens from birth to 2 years. When all his needs are met with, he's taken care of, he's given food at the time, he's given put off to sleep on time, his clothing is taken care of, he's protected from heat and cold. The child acquires a sense of trust in his mother. For this age group, techniques utilizing assistance from parents is advised when this child is brought to the dentist. Usually at this period, the child is brought to you. Ideally, the American Academy of Pediatric Dentistry suggests an appointment before the first birthday so that we can give them preventive information. Usually a natal teeth or a neonatal teeth or initial teething problems like an eruption cyst or something must be the problem when the child is brought to you at this age. For this age group, techniques used like utilizing assistance from parents is advised in the dental operatory. Age 2, this is a period of tremendous physical and intellectual or emotional growth. So toilet training happens, the sense of achievement, when the child is able to control his urge to go to the toilet or make his needs understood by the parent. Self-control and independence also happens with this toilet training. Language capabilities, the child will be able to make his needs and feelings known to the person caring for them. So age 2 is a period of tremendous physical activity, intellectual and emotional growth. At this period, the child keeps running around. He or she has learned how to walk and run. So you have to be cautious about the dental trauma. Vocabulary at age 2 can range from 12,000 words depending on the individual. The child comprehends the tone of voice and facial expression than words alone. The child will be able to understand the parent's mood, the dentist's mood, etc. He or she will grasp and feel objects to totally understand it and fears sudden unexpected movements, loud noises and strangers, which needs to be avoided in the dental operatory when this age group child is brought to you for treatment. At age 3, it is the beginning of preschool years and the vocabulary averages from 1,000 words and the child will be able to speak sentences. In a dental situation, he or she is capable of communicating to the dentist, reacts favorably to positive comments, which can be used to develop a rapport with the child and less fearful of separation from the parent. It varies from individual to individual, but you have to judiciously separate the parent. Age 4 can be very difficult. The child becomes more assertive and bossy at this age. He or she can be an excellent patient with kind understanding and firm direction. In a dental situation, he or she listens with interest to explanation. So tell, show, do works very well. Communication can be established and he or she is responsive to verbal directions, can be very resistant and constantly test limits set for him. So you have to be firm with this child. Fear of unknown is at its peak, so you have to explain to the child every time you are going to do a new procedure. Tell, show, do works very well and reduce fear of strangers. So you and the dental assistant that you have in your operatory are not treated with suspicion, but can be separated from parents. But you have to do your explanations before you actually treat the child. Age 5 marks the end of early childhood. He or she accepts community experience and group activities. Fears are usually dismissed by 5. Proud of his or her accomplishments and possessions, he would come and tell you what he did in school and explain to you what his accomplishments are, which should be listened to with interest and patience. and is particularly responsive to praise and can be used to establish a rapport. 8.6. It is a critical turning point as he or she enters school and becomes a part of the peer group. Success or lack of it can affect his or her self-esteem. So if in a dental appointment, he or she is not able to sit still and go through the procedure, this can affect their self-esteem and will try to avoid the situation as much as possible next time. So you have to show them a lot of empathy if they are anxious and fearful, and may harbor irrational fear of objects, people, and body. So modeling tells you, or systematically sensitization to reduce the fear of objects, people, or bodily harm can be done to make the patient cooperative in the dental setting. 8.7 to 12 becomes increasingly, at this age group, they become increasingly independent of parents and closely intertwines with peer groups. So their observations, their opinions are all based on what the friends have gone through. They will come to you when the friends have come to you before. One of their friends have come to you before, and they have had a good experience. That might be the reason why they chose you as a dentist, and begins to develop a sense of concern and social responsibility. So if you talk to them regarding those things like, maintaining good oral hygiene and how it is important for the general health and well-being of the individual as well as the society, they will be able to appreciate it very well. Learns to question inconsistencies and to conform to the rules of the society. So there are certain rules that the society goes by, so you can use all those to manage their behavior, capable of managing fears in socially acceptable ways. They will be tensed at some points, but they will know how to hide their fear and go through the procedure in socially acceptable ways, and can be usually easily managed in a dental office. What is an emotion? When you know children, you have to understand certain emotion. It is emotions expressed by the children. So you need to know what an emotion is. It is usually expressed by bodily movements, facial expressions, and vocalization. So you have to observe your child patients. Many individuals are not going to verbalize their fears to you or vocalize their fears to you. Put them into words and tell you why they are scared of. So you have to observe their bodily movements and facial expressions to understand their emotions. The commonly seen emotions are cry, fear, anger, anxiety, and phobia in the dental settings. When the patient is not accepting the dental situation or would want to run away from the dental situation, the emotions that we are concerned about are cry, fear, anger, anxiety, and phobia. So cry was classified by SBAT in 1963 into obstinate cry, frightened cry, hurt cry, and compensatory cry. What is an obstinate cry? The child does not want to listen to you. He will close his eyes and open his mouth and make a loud voice, and you will not be able to stop the cry and communicate to the child. Frightened cry you can make out easily from the facial expression of the child. The lip will be lopsided and the eyes will be closed and tears will be running down. So they are so frightened by the situation that you have to calm them, take their fear away, and explain to them that this is not a fearful procedure or a fear-producing procedure. Hurt cries when you hurt them or inflict pain. The child, a tear drop will well up at the corner of the eye and roll down when there is pain, and you will have to be very sensitive to it and keep observing your child patient if you are hurting them. And compensatory cry, they say, is not a cry at all. It is a loud voice that the child makes to drown away the sound of a drill or suction, high volume suction, because they are so scared of the procedure. So they keep crying, but compensatory cry usually does not disrupt your procedure. Anger is caused by the child's lack of skill in handling the situation. So when he or she feels that they are not able to handle the situation, they show anger so that they can escape from the situation. Expressions of anger vary according to the age of the child. Reaction to a known or impending danger is called fear. So this is the consciousness, that is the consciousnness that tells them that this is a situation which they should avoid because it is going to cause harm. Defined as an unpleasant emotion or effect consisting of psychophysiological changes, not just the psychological changes, but psychophysiological changes in response to realistic threat or danger to one's own experience. Factors affecting fear. The major factors affecting fear are the age of the child and the gender of the child. Fear factors: fear of pain. Lack of trust or fear of betrayal. You tell them you will do something and you are going to do something else. Many times, somebody must have told them that they will not do harm them, and then must have given an injection. So lack of trust or fear of betrayal, fear of loss of control. They feel that, if they sit on the chair and at one point they will not be able to tolerate the procedure and would start crying, they would try to avoid the situation. Fear of the unknown. Fear of the unknown means fear of they have no idea about what paraphernalia and equipments you are going to use and whether they will be able to go through it. So what is going to happen is unknown to them. The treatment procedure is unknown to them. So here you have to do, tell, show, do, and you have to tell them, you have to find out the reason for the fear, and you have to alleviate fear accordingly. Fear of intrusion into their personal space is another fear of the child. So all this needs to be taken care of before you actually render treatment. Fear of pain, lack of trust, or fear of betrayal, fear of loss of control, fear of unknown, or fear of intrusion. The types of fears are innate fear. Innate fear is without stimuli or previous experience, depends on the individual's vulnerability. Subjective fear, fear transmitted to an individual from family, friends, or media. Somebody must have told them, or they must have seen somebody going through a dental procedure in an unpleasant manner, or must have seen some cartoons or some media where dental procedure is being done in a painful manner. Objective fear is due to specific conditioning, events, objects, or previous experiences. Some injections or vaccinations which would have been done earlier might have caused pain for them. The patient does not want to go through the same situation. Response depends mainly on age. It can be at 3 levels. In an adolescent child, you see an intellectual response to fear, whereas in a school-age child, it is emotional and hedonic in very young children. They don't know what fear is. So they will, go through the procedure. They will only if you inflict pain or they face pain without much emotions, or they might cry. Anxiety. Anxiety is an emotion similar to fear, but has no source of danger or reaction to unknown danger. It depends on a person's imagination. It is not an immediate emotion. It keeps building up. If you make the child patient wait outside the operatory in your waiting area for too long a time, they might sit there and assume things and get anxious. It can be defined as a state of unpleasantness or unpleasant feeling combined with an associated feeling of impending doom or danger from within rather than outside. So emotion is similar to fear but has no source of danger or reaction to. It is a reaction to unknown danger. So it is from within rather than from outside. Please remember that. There are different types of anxieties called the trait anxiety, state anxiety, free-floating anxiety, situational anxiety, and general anxiety. Trait anxiety is a temperamental feature, whereas state anxiety is an acute situation-bound episode. Free-floating anxiety is persistently anxious mood, and cause of anxiety is unknown. And in situational anxiety, it is only to specific situations or objects. Whereas general anxiety is a chronic, pervasive feeling of anxiousness irrespective of external circumstances. Causes of anxiety are uncertainty, previous learning or experience, biological difference due to innate biological mechanism of the individual. Anxiety can be measured by different anxiety rating scales. We have response to picture cards called the Wenham's picture test, verbal questions, and a questionnaire, which will measure the anxiety of the individual. What is phobia? Irrational fear resulting in conscious avoidance of a specific feared object or activity or situation. That is an irrational fear. There is no rationality to that fear. That will result in conscious avoidance of a specific feared object, activity, or situation. It may be defined as a persistent, excessive, unreasonable fear of a specific object, activity, or situation that results in a compelling desire to avoid the dreaded object. They will at any cost avoid the object, situation, or activity. Depending on the causes, phobia can be simple phobia, situational phobia, or social phobia. Simple phobia is isolated fear of a single object, person, or a specific situation. Whereas situational phobia is popularly interpreted as fear of open spaces, which has wider implications like fear of crowded places, public transport, being alone at home, etc. It refers to a cluster of complaints. Social phobia is fear of being looked at, concern about appearing shameful or stupid, etc. Example is public speaking. Thank you. You have an assignment. You will have to find out about different anxiety rating scales and write an assignment on anxiety rating scales. If there are any questions, kindly feel free to mail me the questions. Thank you.